At the outset, I would like to thank Dr. GVK sir and the organizing team for having me here today, and thank Novo Nordisk for having to be in this session. Yeah, anyway, just to save time, let me start off. So what I will be talking in the next 10 to 12 minutes or so is to mainly look at how somebody develops obesity and what are the interventions that we currently have to help these patients tide over obesity and probably cut down their metabolic risk. Now, as with any chronic metabolic or lifestyle disease like type 2 diabetes, hypertension or CVD, obesity is no more just a phenotype, but we consider it as a specific disease entity because we know from the fact that weight gain or a dysfunctional or an excess adipose tissue is the root cause for all metabolic perturbations that we actually come across with all the cardiovascular, renal and metabolic diseases. So when we talk about obesity, it is generally said that any energy balance is maintained with a simple equation of calorie in is equal to calorie out. But it is not as easy as it sounds because we know for the fact that the energy balance cannot be just so simple. So when we talk about calorie in and calorie out, we would have seen people who eat such high amount of calories, yet they do not gain weight. At the same time, we will have people who count their calories before consuming and would still not be able to lose weight. So it's not just about the calorie in and calorie out, but many other factors contribute to weight gain and obesity, and that is what makes it as a disease entity and not just mere phenotype. So when we talk about the factors that contribute to obesity, we need to understand that genetic predisposition is the most strong component that somebody would actually gain weight. So 60 to 70% of weight, of our body weight, is contributed by genetic predisposition. Now, besides the monogenic forms of obesity, which we all know, which is quite rare, we have the polygenic forms of obesity, where you have a lot of MCR4 mutations, the fat mass and obesity associated gene mutations that contribute significantly to the weight. So without a genetic predisposition, we will never get somebody obese. So genetics still plays a major role in terms of obesity. Now beyond obesity, you have other factors like biological factors, wherein you have the appetite system which becomes dysregulated. We have the psychological factors, stress factors, because we know that when somebody is sad, they eat. They are happy, they eat. They are stressed, they eat. Just like smoking, no? In movies, they say when somebody is stressed or they want to really think more, immediately they start smoking. So similarly, eating has become a stress reward, and therefore whenever people get stressed, they start eating and eat more. Especially they have a potentially increasing appetite for high fat and high carbohydrate diet. So then you have the environmental factors. We have easy access to calorie dense food. We have unhealthy eating patterns, erratic meal schedules. Medications, again, the steroids, the anti-epileptics, antipsychotics, and even sulfonylureas can potentially make somebody gain weight, and the social components, which we all know. So what I'm trying to say is that there is a core genetic component for all obesity, with so many other factors confluencing the epidemic of obesity in a given individual. Now, when we talk about the appetite regulation system, there are three things that come into play. Now, one is called as the homeostatic regulation or the homeostatic eating. What we mean by homeostasis is once the energy reserve or the energy balance goes low, the body gives a peripheral cue, and that gives signals to the hypothalamus. Hypothalamus produces signals to increase hunger with a lot of peptides coming into play, and the moment we are motivated to eat, the hunger settles down. So this is basically a neurohormonal activation of the appetite regulating system, and that is mainly driven only when the energy reserve goes low. On the other hand, you have the hedonic eating system, where the eating is mainly done for pleasure. It's not mere hunger, not mere energy deficit, but somebody wants to eat. As I said, somebody gets stressed, they eat. They're happy, they eat. They want to enjoy. Say they've scored well, they give a treat. So something like more of pleasure-driven eating. Now, having said that, they don't exist as two separate entities. They are quite interconnected. One influences the other. And most importantly, what we need to understand is the hedonic eating most of the times overrides the homeostatic eating. By that I mean to say that the pleasure eating overrides the energy deficit eating. And that is the reason why obesity sets in. Now, then you have the executive function where once you become hungry, just like how we are all now before the lunch session, the decision of eating, how much to eat, what to eat, it all depends on your environmental factors and your behavior. So that is the reason why behavioral therapy becomes most important and relevant when we manage patients with diabetes, because we don't want to just target the homeostatic eating and hedonic eating, but also this executing function without which none of the weight loss programs are going to be successful. Now, what are the peptides that are involved? The homeostatic eating, as I told you, revolves around a lot of peptides. So you have the orexigenic pathway, which stimulates the appetite, and the anorexigenic pathway, which suppresses the appetite. So the orexigenic pathway is mainly driven by our GLP-1, the polypeptide YY, oxyntomodulin. Oxyntomodulin is a physiological dual agonist. Just like tirzepatide, you have a physiological dual agonist of GLP-1 and glucagon. Then we have pancreatic polypeptide, amylin, insulin, and leptin. So all these hormones are anorexigenic and they suppress the appetite. On the other hand, you have the orexigenic pathway where you have ghrelin, you have agouti-related peptide, neuropeptide Y, all these hormones stimulate hunger. So unless there is a balance between the orexigenic and anorexigenic pathway, patients do remain hungry for a longer period of time and they end up consuming more. So this hedonic eating pathway is mainly driven by dopamine and the cannabinoids. So this is basically as a reward system. You do good, you eat well. You score well, you eat well. And that is how this reward system works. And the behavioral therapy, as I told you, depends on what you think that you would eat and what would give you that happiness, what is accessible for you and all that. So all these three domains of appetite regulating system has to be considered when we are dealing with a patient who primarily has obesity and complications where you want to help them out with some weight loss. Now, lifestyle intervention is the most important and the first and foremost pillar of any weight management. We all know about the calorie deficit that we need to create by increasing the calorie expenditure and decreasing the calorie intake. Now, weight loss is due to lifestyle intervention can go up to the tune of 3 to 5%. So that gives you the metabolic benefit, though may not help in diabetes remission or something, where from the direct trial, we know that unless there is a very low calorie diet, the diabetes remission doesn't happen. So lifestyle intervention is important. And what they have shown is the 3 to 5% weight loss, but unfortunately, the weight gain happens much higher than the pharmacological intervention. So at around 2 years following the weight loss, 50% of the weight is regained. And at 5 years of following the lifestyle mediated weight loss, 80% of weight is regained. So what I'm trying to say here is lifestyle interventions do work and will have to be incorporated into the weight loss regime, but the rebound weight gain is much higher, making ourselves and patients helpless when we are just sticking on to lifestyle intervention, especially with a morbid obesity. So there has been a constant struggle between weight loss and weight gain. We have so many factors acting towards weight gain, so many factors acting towards weight loss, but it's a constant struggle. I'm sure we have all encountered patients who lose weight and quickly gain weight, making it no different from what they were before. So pharmacological interventions, especially the GLP-1 based therapies, have helped us to modify the brain regulated appetite control system. So that way we are able to potentially correct the pathological abnormality, just like what we do so in the management of type 2 diabetes. We are able to regulate the appetite control system with GLP-1 based therapies like semaglutide. So semaglutide, the subcutaneous version of 2.4 milligram, which comes in the brand name of Wegovy, helps modulate the appetite control system in the brain. So basically what it does is it acts primarily at the hypothalamus, at the arcuate nucleus, at the appetite regulating control. So you can see here that it acts at the amygdala, which potentially gives you that feeling of eating. Basically, it gives you the feeling of having some food, having something to munch and all that. So that is completely inhibited with semaglutide. On the other hand, the peripheral cues that tell you that you will become hungry, your tummy is empty, you need to fill in some calories, that has also been inactivated. So that way you have a peripheral action as well as you have a central action that helps you to modify both the hedonic as well as the homeostatic regulation of the appetite control system. So that way, it's a centrally acting drug predominantly, which makes it even more efficacious with regards to weight loss, unlike our peripheral drugs like metformin and alpha-glucosidase inhibitors, which have a peripheral action, especially in the gut, which slows down, gives you that satiety, but does not have an effect on the brain or on the appetite control system, and therefore doesn't translate into a good weight loss. Looking at the efficacy of this molecule, we have the STEP series of trials comparing with placebo, with diabetes, without diabetes, with metabolic complications, with mechanical complications like OSA and arthritis. And it has also been studied in adolescent population, which many times we do not have the other GLP-1 analogs. They have also looked at it in patients who had high cardiovascular risk like HFpEF, and also the patients who had MASH. And overall, all these trials, including the STEP 1 and 2, SELECT and STEP HFpEF, which is mainly done with Wegovy 2.4 milligrams, the SUSTAIN group of trials done with 1 milligram of subcutaneous semaglutide, and the PIONEER trials, which we are all familiar, which takes care of oral semaglutide. So there is a good amount of Indian representation in all of these trials, so we are able to extrapolate the benefit that this molecule can offer to our patients as well. So the STEP 1 trial primarily compared Wegovy 2.4 milligrams versus placebo for a period of 68 weeks, and this included patients who had obesity with or without comorbidity. Now, what they actually did is they started with 0.25 milligram, up titrated to 0.5, 1.7 mg, and stabilized at 2.4 mg for a period of about 52 weeks. And what they actually showed is that compared to the placebo arm, which showed a 2.4% weight loss at the end of 68 weeks, the patients who were put on semaglutide 2.4 milligram subcutaneous did have a greater weight loss, and this comes as no surprise. So a 16.9% body weight reduction was observed at the end of 68 weeks. Now, when they looked at how many people were successful in achieving this weight loss, they saw that 5% of body weight loss was achieved in close to 92.4% of patients. More than 10% of weight loss in 74.8%. Now 15% weight loss, which is actually required for diabetes remission, happened in half of this population, and 20% of weight loss in more than 1/3 of population. So that gives us an idea as to the response that this molecule can offer to the patients who are put on this molecule. Now, when they looked at the other benefits, again, the numerical reduction with waist circumference, systolic blood pressure, diastolic blood pressure reduction, CRP reduction, A1C reduction, more importantly, the functional score. Patients who had osteoarthritis did show a better functional score because the weight came down and then mobility improved. Now, the STEP 4 primarily looked at Wegovy, when what really happened when treatment was withdrawn. Because whenever we are worried about rebound weight gain, we want to know whether patients will be able to manage without the drug. So what they primarily did is they did patients put on Wegovy and Wegovy for a period of 20 weeks, and then one group continued Wegovy, the other group stopped Wegovy. So what they showed was when patients stopped Wegovy, they had a 6.9% increase in the weight after the initial weight loss, and whereas patients who continued on semaglutide 2.4 mg did show an 18% weight loss at the end of 68 weeks. So that tells us that just like how we tell patients for diabetes and hypertension and CAD, most of these weight modification regimes and drugs probably need to be continued given the fact they are expensive, but more than that, this is how chronic disease has to be taken care of. Now, this is the long-term data. What they actually showed was even until the end of 2 years or 104 weeks, the weight loss that was initially achieved at the end of 68 weeks did sustain for up to 2 years. So that gives you the amount of less of rebound weight gain or the increase in the calorie intake did take care, and there was no much weight difference when patients were continued on Wegovy. So the adverse events were very much comparable. Of course, the GI effects were much more in patients who were on semaglutide, but as we know, when we gradually titrate it, we don't have a problem of withdrawal or discontinuation of this molecule. So to summarize, the semaglutide subcutaneous injection does really help with regards to weight loss, with regards to metabolic benefits, but the most important thing is patients need a good counseling, lifestyle modification, and then pharmacological intervention, which is very much worthwhile to not just treat obesity, but also to prevent the obesity-related complications like CVD, type 2 diabetes, and CKD. Now, the efficacy of the drug has been clearly studied. We have close to 20% weight loss at the end of 68 weeks. And this weight loss is sustained even at the end of 104 weeks, which is about 2 years. And not just the weight loss, but also metabolic benefits, cardiovascular benefits, renal benefits, and the physical ability score did improve in patients who were put on semaglutide. So thank you very much, and I'll close my presentation here. Thank you.